लोगों को नहीं मालूम ना।
नहीं बोलते हैं आपकी तरह स्टाफ मारो बोल के बोलते हैं, मगर उन्हें नहीं मारते।
हाँ, लेकिन अपन मार लेना ना। 4 घंटे 6 घंटे चलते रहता ना।
नहीं, बिना बोल के चले गए तो मुश्किल होता सर।
तो तुम इंस्ट्रक्शन दो ना फिर।
नहीं, देने के बाद भी वैसे ही छोड़ो।
तभी करना चाहिए, सबका नुकसान है ना उसमें। हाँ, good afternoon students. Yesterday we have considered in detail about the question papers of 2016. We have finished major number 2 questions. We have taken slightly longer time for that, but they are equally important. For short note, even in practicals, these questions are bound to come regarding varicose veins and regarding breast. I am very sure everybody will have at least one case in their practical exam. That has taken more time. So at present, we will be dealing with the question number 3. So that question will be now today considering comparatively. Okay, this is also major question, inguinal hernia. In fact, this is a most important question for the practical examination by YYOC. In theory also they have asked, the question is discuss the causes, clinical features, complications and management of inguinal hernia. That means every aspect of inguinal hernia is completed. They have not mentioned whether you have to talk about direct hernia or indirect hernia. So inguinal hernia per se is a term which is all inclusive. So we have to discuss causes, clinical features, everything. Causes means what is the etiology? Why does the hernia occurs? First, how do you define hernia? This hernia is a protrusion of a peritoneum or sac into other sac. That means invasion of one tract over the other. Herniation is a process. Herniation means going from one field to second field. This is very simple. From one territory you are entering into another territory. That is herniation. Herniation is a very simple term. This is invagination into others categories. This is attacking other category. That means hernia which has been restricted to abdominal cavity or any cavity has come out into different cavity. Okay, this is the simple definition of hernia. Hernia is herniation. What is etiology? The commonest etiology we are dealing with is, you can see here, it is a but just so this is an indirect hernia occurs in a congenital preformed sac. Simple. This what is this sac? This sac is a remains or remnant of processus vaginalis. That means during the descent of a scrotum, there is a sac which normally is obliterated. Any patency of that processus vaginalis tract will lead to indirect inguinal hernia. Other causes are some weakness that will go to direct inguinal hernia. We will consider afterward. To start with, the chances of a bilateral preformed sac are 60%. That doesn't mean that everybody is getting bilateral hernia. But once hernia, other side is potentially affected to form a hernia. Okay. Causes are in general strain, lifting of heavy weight, chronic cough, constipation, old age like BPH, carcinoma prostate, in young age, stricture urethra, very young age in children. Most of them are congenital hernias, but sometimes phimosis. What phimosis does? It will have a constant pressure for the child to pass urine or meatus stenosis. So this pressure also can give rise to herniation. Obesity, pregnancy and pelvic anatomy. Because pelvic anatomy, pelvis is wider in female as compared to males. It is more transverse. Because of that, anatomical disposition, the femoral hernia is common or only occurs in females. So these are the causes. Smoking, ascites and these days appendectomy done through McBurney where one of the nerve is cut will also give rise to hernia formation. The present day concept is, I told you last time, it is a collagen disorder. And in the collagen, this Prune-Belly syndrome is very common. And this acquired herniation, you see many of the hernias, even indirect, occur in very old age. Then what is the cause? Why should he have a congenital hernia in that age of 40, 50? There they say it is a deficiency of a collagen. The collagen type of collagen is soft collagen, hard collagen. That collagen deficiency itself will lead to herniation. So what is the treatment now we are doing? Amongst all, putting the mesh, the collagen is deposited, fibroblasts are deposited, and that forms another wall. That means the mesh is taking care of this collagen deficiency. This day, this is considered to be a major cause. Okay, so we have considered the causes. So if you just want to remember the precipitating causes for inguinal hernia. In fact, there is no cause except obstruction, because they are challenging number of causes. But for the sake of understanding, smoking, obesity, asthma, ascites, previous surgery, chronic constipation, urinary problems, strain, and multiple pregnancies. Multiple pregnancies are known to give rise to herniation because of the weakness which occurs in rectus abdominis. Okay. So, how do you classify? Classification of hernia is on different grounds. We'll consider all of them, in fact. Okay. Major classification is clinical. This classification which we daily come across in a practical. You have to describe what type of hernia it is, the descent of hernia, as well as whether the hernia is reducible or not. So clinical types: reducible hernia, irreducible hernia, obstructed hernia, inflamed hernia, not obstruction, inflammation of the hernia, and the termination is strangulated hernia. So these are the clinical classification of a inguinal hernia. Frankly, we are talking about indirect inguinal hernia. The second classification comes is, simply put, congenital acquired. Congenital is more common because by definition this is occurring in a preformed sac. Acquired means there is no preformed sac, but there is a deficiency or excessive pressure. What it is? A rise in the intra-abdominal pressure and weakening of the posterior inguinal wall. That is the major cause for DIH, that is a direct inguinal hernia, posterior wall deficiency, and all surgeries are directed towards the reinforcement of the posterior wall. Okay. The classification which is now commonly used on anatomical grounds, on investigations, is called as NYHUS, that is a NAHES classification. This may be asked in exam. What it says? It is probably more useful. Type 1, indirect hernia with normal deep ring. Remember, the indirect hernia with normal deep ring means the surgery is, simply put, it is excision of a sac. Grade 1, type 1. Type 2, indirect hernia with a dilated deep ring, where you can pass a finger inside a ring. That means there is also associated cause of a deformity. Type 3, here it is not the internal ring, it is only the posterior wall defect. Here comes all types of direct hernia, all pentalum hernia. Pentalum means two hernias together, direct plus indirect. Femoral hernia, this also is a weakness. Femoral hernia is weakness in the posterior wall of the hernia, in the inguinal canal, the femoral canal. Okay. And type 4 is recurrent hernia. For this, the causes and everything is totally different. 1, indirect with normal deep. Type 2, indirect with dilated ring. Type 3, posterior wall defect. Type 4, recurrent hernia. It is very simple to remember NAHES classification. Okay, you must remember this. So coming to clinical features. Very commonly asked question. What are the clinical features of a hernia? Understand, it is a prevalence into males. Saying a femoral hernia apart from femoral in a female, you must think 10 times. Never commit yourself that this is a female hernia. And remember, direct inguinal hernias do not occur in females. Never make this mistake. Whenever you talk of hernia in females, you should be very sure most likely it is a type 4 NAHES, that is, it is due to the previous surgery. That means incisional hernias are common in females and femoral hernias common in females. Never say direct hernia in female. Okay. So what are the presentation? Dragging pain, swelling in the groin, which is more prominent on cuff and standing. This is a definition. And this is called as expansile impulse. So in definition of hernia, patient dragging pain, swelling with expansile impulse. That means swelling gets prominent on a cuff or elevation of legs. Okay, this is the definition of hernia. So what it is? Momentary increase or occurrence of swelling during act of cuffing. See what is happening here? At the time of cuffing, the hernia is prominent. Moment it stops, moment pressure is not there, hernia will disappear. So this is whether the hernia is there or not, you can diagnose only on cuff. But this is, we are talking of an incomplete hernia. If a complete, there will be continuous descents right up to the scrotum. So this hernia is called as complete hernia. The major differentiation from the hydrocele is one cannot get above the swelling. This is, you must remember by heart. In a hernia up to scrotum, you cannot reach above the swelling, which is possible in case of hydrocele. Okay. What are the contents? Commonest is mesentery, omentum, small bowel, then large bowel, or any combination of them. Any combination of these can come into hernia sac. In females, you may get ovary or tubes. In infant, how is the presentation? It is a congenital hernia. That is why whenever child cries, this swelling becomes prominent. And this swelling is translucent. So which hernia is translucent? Infantile hernia is translucent. Okay. If it is reducible but can go to irreducibility, inflammation, obstruction and strangulation. So these are the next stage. To start with, this may be reducible but it can go to further more. What are the tests we are commonly doing? Internal ring occlusion test. This is very simple. One must do it in practicals. So what it says? If a swelling does not appear on releasing of the thumb, the swelling appears during cuffing, then it is indirect. That means a pressure over an internal or deep ring. Even with cuffing, the hernia will not manifest. That is why it is an indirect hernia. So if comes out, then it is a direct inguinal hernia. That is the differentiation between direct and indirect hernia. In our next slide, we will consider in detail. Most of the examination hernia should be done in standing position. Okay, this is a basic test. Other test, remember the names and do in practical. A ring invagination test, that means you have to see the size of an internal ring. Sometimes head or leg raising. If your leg are raised, the hernia will become prominent. Head raising, same thing. What it does? It increases intra-abdominal pressure. Sometimes PR examination also. During PR, you can find prostate is enlarged. And in hernia in females, what you see? A thickening of a labium majorum. There is a classical sign which is called as silk glow sign. What this sign is? Here, if you palpate by the side of a pubic tubercle, the hernial sac, empty hernial sacs can look or will be palpated like a multiple silk sari layers. It will be rough over your finger, but you can palpate them. That is called as silk glow sign, as if you are wearing a gloves from a silk material. Understand? So this is regarding the clinical features. So this page is important. You must read it carefully. This is from Leventhal, nothing very extraordinary. Indirect inguinal hernia, direct inguinal hernia. How do you compare them? This is most essential. Indirect inguinal hernia and direct inguinal hernia. Indirect, any age from childhood to adult. Direct, common in elderly. Occurs in pre-existing sac. By definition, indirect is sac. Direct, acquired. Indirect, protrusion from the deep ring. Here herniation from the posterior wall of the inguinal canal. The shape of indirect piriform in shape, oblique descent and downwards, oblique and downward descent. Globular, round in shape, descent directly, that is a forward bulge. The indirect can become complete up to scrotum. The direct hernia does not descend into scrotum. Sac is anterolateral to the cord. This is during surgery, it is very important. In indirect hernia, first you see is a cord. But about the direct hernia, cord is posterior to the sac. Okay, you must remember this. Ring occlusion test does not show any impulse after occluding the deep ring. So this is nothing like in direct hernia. Invagination test, impulse at the tip. Same test, impulse at the pulp of finger. Remember how do you introduce? On right side you introduce left finger, on left side you introduce right finger. So this is the basic for practicals. Zeeman test shows impulse on the index. Okay. Unilateral, indirect, commonly unilateral, but can be bilateral. But because of the pathology itself, direct hernia are more likely to be bilateral. All the complications which we think of obstruction strangulation are common in indirect hernia. They are very rare in direct hernia. And major operative difference, sac should be opened during surgery in direct hernia because there can be adhesions of the omentum to the sac. Similarly, in direct hernia, you are not required to open the sac unless there is obstruction. So that means the sac is simply invaginated in case of direct hernia. In direct hernia, open the sac and see. Few people in conjugal hernia do not open. That is different. But ideally this is so. Now coming to the complications. This is the question asked. What are the complications? Complications are simple, very common. First is irreducibility, because reducibility is the nature of hernia, herniation. So irreducibility, the reason, commonest reason is long-standing adhesion formation. Edema of the cord itself, if it remains longer time into the hernia sac, there will be edema. Next complication is sliding hernia. Hernia will keep on from one side. That means posterior wall of the hernia will be made of some internal organ. Feces can be impacted into hernia. Very rarely it can rupture due to trauma. That means hernia sac is outside and trauma occurs over inguinal region. It can rupture. Pressure necrosis of overlying skin. Long-standing indirect hernia which is not going inside can give rise to pressure necrosis of skin. Very rarely fistula formation. Other complications are like Rister's hernia, and major complications are, apart from irreducibility, obstruction, incarceration and strangulation. So remember only 4 major complications: irreducibility, obstruction, incarceration and strangulation. Okay. Now comes the management. Management of hernia is fortunately very simple. Diagnosis simple, management simple, surgery simple. Everything is simple in hernia. But bad part is recurrence. Recurrence is the worst part. That is why so many surgeries are coming in. One major thing, all hernias need surgery. There is no role of conservative management. Understand? There is no role of conservative management except temporary. That means an old man or he has to arrange something. Till that time you can use truss. Hernia truss is available in market where it will keep pressure on the internal ring so that hernia doesn't come out. Second part is preparation. Preparation for hernia surgery is physiotherapy. What is the physiotherapy? You have to strengthen the abdominal wall. This is a good practice. If you after one month you have time, you always go for abdominal strengthening of the wall. And most important is weight reduction, because obesity always comes in the way of recurrence and in the way of surgery. More important, everybody, my friends, remember, patient has to stop smoking at least 1 month before surgery. This is by law. You must ask the patient to stop smoking because smoking is also one of the major cause of recurrence. So what are the surgeries? Simply put, herniatomy. What it is? Excision of the sac without repair of posterior wall because it is not defective. So this is done in congenital, pediatric or infantile hernias. Okay. Next is herniorrhaphy. Rhaphy means repair. What are we repairing? We are repairing the posterior wall. Simply posterior wall repair with a suture. This is called as a anatomical repair. Now anatomical repair is taking more importance. This is started with number of old operations like Bassin's operation, extra we will discuss. And next is hernioplasty. What it is? Plasty means you are repairing the posterior wall with some artificial material, that is a mesh. So excision of sac is primary. Amongst all types, sac has to be excised, except in direct hernia where sac is invaginated. So this mesh repair is nothing but the famous Liechtenstein repair. And now commonly done by all young people is laparoscopic repair. So there are 5 types: herniatomy, herniorrhaphy, hernioplasty, laparoscopic repair. These are the different types of herniation. We are talking of a congenital, this indirect hernia. There are different ways for managing incisional hernias. Okay, so these are the vision. In short, go through this table. What are the anatomical repair? Bassin's repair, modified Bassin's repair, McVay repair, where Cooper ligament is the indirect ligament, is repaired. Maloney-Darning repair, that means Darning means taking multiple layers. Multiple layers by what? With the help of fascia lata. That is a darning of the wall. That means posterior wall is reformed. Schultes repair. We are not doing, but there is an academy of Schultes repair. They are doing exclusively Schultes in UK. And in India, we should be proud that one of our surgeon, Dr. Professor Desarda, has come out with an anatomical tissue non-mesh repair technique. And now this technique is gaining worldwide importance and it is mentioned in the SRB book as well as in the Love and Belly, our last 27th edition. You can go through that. Here mesh is not repaired and the external oblique has been used to form the posterior wall. Okay. And now the commonly done in our college is a mesh repair. Posterior wall is strengthened with the help of mesh. Mesh we are using is a Prolene mesh. Technique called as Liechtenstein. Different methods: Gilbert's plug repair, Prolene hernia system. This is a ready-made system available which will fit into the internal ring. And laparoscopy, it is TEP, that means total extraperitoneal repair, and this is TEPP partly through the peritoneum. Tap and tap. Okay, these are the different methods. So we have come to the conclusion of a hernia. What are the causes? What is the classification? What are the complications and the management of hernia? This is a question we have solved. Okay. Next comes the question which is also equally common. This question regarding the duodenal ulcer bleeding is common for a theory, short note, as well as actually when you come into practice. You can always expect a bleeding duodenal ulcer in your private practice. So you should be aware what it is, what is the primary management, what is the secondary management, what are the causes. So what? Introduction. Upper GI bleeding, the commonest cause in our country is a acute duodenal ulcer. Acute ulcer bleed, chronic ulcers fibrotic. Fibrotic ulcers do not bleed. Chronic ulcers perforate. Acute ulcers bleed. In simple. And what do you mean by massive? Massive hemorrhage means need of more than 5 units of blood transfusion. If you remember last lecture, we have considered massive hemorrhage in details. 5 units is the total blood available in the body and that much blood is lost within a single day. That is a massive hemorrhage. Remember, what you have earned through your 40, 20, 25, 50 years, you are losing within a single day. And by definition, what is upper GI bleeding? Upper GI bleeding means bleeding from the source proximal to ligament of Treitz. Last time I told you. And that is called as upper GI bleed. Lower than ligament of Treitz, lower GI bleed. But even because of the blood in the stomach, patient can give rise to melena. And unfortunately, the stools have got a very foul smell and black colored. So coming to the causes. This is a question, causes. This graph I think we should remember, it is very simple. There are two major causes of upper GI hemorrhage. Number one is non-variceal hemorrhage. Number two is variceal hemorrhage. That means whenever the bleeding is occurring from the esophageal or stomach varices, it is a variceal hemorrhage. But remember, this is only 20% common. It is massive, but fortunately it is not very common. What is common? Non-variceal bleeding, which is 80% common. So where this comes from? This is coming from different sources, but all sources are from esophagus to the duodenum. Commonest is peptic ulcer. Now remember, peptic ulcer is defined as duodenal plus gastric ulcer. They do not differentiate now, because clinically also it is very difficult. You can differentiate only by the help of gastroscopy. Others are wrong. The relation of food, before food there is pain, after food there is pain, those definitions have gone. It is only on the anatomical side. Remember this for safety, clearance. 40% causes are peptic ulcer. Second, 20% gastritis, inflammation of the stomach or duodenum can give rise. This is more common cause. Esophagitis, inflammation of the esophagus. And this syndrome they can ask, Mallory-Weiss syndrome or Mallory-Weiss tear in the lower end of esophagus or upper gastric end. It is a 5%. This can give rise to massive duodenal hemorrhage. AV malformation, others. But see here in this graph, cancer is only 2%. That means the carcinoma of stomach, duodenum, they are rare. They rarely present as a hematemesis. So if it is hematemesis, don't be afraid of malignancy. You are likely to have a non-malignant cause. Amongst variceal, the varices can be esophageal or gastric. They are commonest, 90% of them. Sometimes gastropathy. This pathy is because of portal hypertension. It causes 10% of the causes. So 80% non-variceal, 20% variceal hemorrhage. So understand, these are the causes of upper GI hemorrhage. So in short, if you just want to understand bleeding peptic ulcer, this is either from a duodenal, gastric or a stromal ulcer. This is the entity because so many patients are operated for anastomosis. Anastomosis can also form an ulcer and can bleed. What is so important? Mortality 20 to 30%, very high. More mortality in old age. Commonest cause is H. pylori and NSAID. Anticoagulant drugs, what the patient has to take because of angioplasty, it can be one of the cause. And this NSAID steroid increase the risk by 10-fold. That is why we should rarely advise these drugs to patient for a chronic use. For a short-term use of 3 days, no issue. Okay. And this diagram you can very well find out from book. This is an anatomic of the gastric arteries. This is the blood supply of stomach. So common for us is question asked regarding bleeding duodenal ulcer. It is 10% common, and this is more common in patient who has not received anti-H. pylori treatment and PPI. This is proton pump inhibitor. If the patient has not received this treatment, chances of bleeding are very, very high. Hence, never stop this PPI and H. pylori treatment to any patient of duodenal ulcer. So, precipitating causes. What causes actual bleeding? Common alcohol, NSAID, steroid, Atherosclerotic disease, because of atherosclerosis, the blood vessels cannot contract. This is atherosclerosis, thickening of the wall. So this is a precipitating cause. But the clinical features very simple. Commonest hematemesis, melena. Features of shock. I have talked about in detail about the shock. All features of shock may be present. Pallor, tachycardia, sweating, dry tongue and cold paresthesia. In some patient may give history of DU. But silent ulcer, that means DU can present for the first time as a duodenal ulcer bleeding. Okay. So what are the differential diagnoses we have considered? Non-variceal and variceal. Gastritis, CS stomach, bleeding gastric ulcer, syndrome and gastric polyp. So these are the differential diagnoses. You can write down. How do you investigate? Investigations are very simple. PCV means concentration and hematocrit, ESR. Hemoglobin is not very sure call because there is a concentration. Blood group must be done. Serum electrolyte, blood urea, creatinine and platelet. All blood investigations has to be done including blood group. And the commonest or confirmatory is gastroscopy. Nowadays one must perform gastroscopy either within 6 hours or within 24 hours. If the cause of the bleeding is not found out, then we can go for celiac angiogram. This will give us the where the RBCs are going. So this is the most 100% diagnosis in this is celiac angiogram when the gastroscopy is not confirmative. How do you treat them? Treatment is probably more simple than it looks. 70% of bleeding duodenal ulcer are treated conservatively. Don't be afraid. Most of the treatment is conservative. How do you correct it? Shocks to be corrected by our general principles here. Again same. Foot and elevation, IV, CVP, sedation, catheterization, blood transfusion, and in addition to that, here it is a stomach wash. How do you wash it? First aspirate the blood, because aspirating blood keeping there also can be give rise to reduction of clotting factors. So it must be removed. Clot must be removed, and washing with 1:2 lakh of the adrenaline. This is a mild solution of adrenaline saline wash is given through rice tube. So rice tube is for the management of blood as well as this adrenaline wash. And IV ranitidine, IV pentaparazine. So these are the advanced management. Non-surgical. Endoscopic cauterization of a small vessel through gastroscope. Nowadays laser is used or some type of clips. Hemo clips are the best. They are the this treatment of choice at present. Sclerotherapy. Ethanolamine. This is injected directly into the base of the ulcer. And even adrenaline can be injected. So it is a epinephrine injection used very commonly now. Old age, acetyl alcohol, polidecanol. This drug is taking over. And if it is not possible or bleeding is severe, then by the help of radiologist, we can go for what is called as angiographic immobilization and hemoclip. Remember the things in red. As usual, my policy. Write down endoscopic cauterization, sclerotherapy, epinephrine injection, embolization, hemoclip. Then you have got 100 out of 100 marks. So this is we are talking about non-surgical management. So what are the indications for surgical treatment? Whether surgical treatment is indicated or not. Because 70% to 80% patients are responding to conservative management. So what are the indications? This is general, but now latest guidelines have come. That also we'll consider. The patient deteriorating in spite of conservative management. Bleeding from gastroduodenal artery. This is the posterior artery and it is a major artery, bleed profusely. A recurrent bleeding, that means patient has bleeding for the second time, third time. Old age patient, why here? Atherosclerosis is more common in young age and either 4 or 5 units of blood are required immediately. With this requirement, surgery is indicated. So this is a classification. This is for somewhat higher rank. What it is? Whenever bleeding is less, so this is called as a Forrest classification. Why this classification is important? Because it is for the rebleed assessment. We classify because whether the patient is going to bleed again or not. You have stopped the bleeding. How many chances of rebleed? That is by the Forrest classification. Grade 1A. It is active pulsatile bleeding. Grade 1B. Active non-pulsatile bleeding. See, this is bad. Grade 2A. Non-bleeding visible vessel. That means vessel is visible in this case. Grade 2B. Clot is adherent. Grade 2C. Only black dot. Grade 3. There are no signs of bleeding. The patient is improving. So, what are the high risk? This grade 1 and grade 2A. These are the high risk patients which are likely to bleed again and again. So what? Here there has to be some permanent management, that is by the surgery. So these have immediate risk of rebleeding. These 2, 3, they have less risk. They can be treated conservatively every time they come. No surgery required. So for the treatment, 1 and 2 high risk. Here endoscopy must be done within 24 hours, preferably 6 hours. Immediate treatment, resuscitation. Medical management, PPI H. pylori. Local injection, epinephrine adrenaline, dilated, and 13 ml is injected in all 4 quadrants. In all quadrants, you have to inject epinephrine. That is very important. You can write down that. And whenever you combine these all, that means what you are combining? Epinephrine plus laser. This combination is very good and most effective. And for active bleeding like this, it is an endoclip. So remember this chart, you have got to treatment everything. Surgical, 5 to 10% needs surgery. What is the surgery? Just chart is more than enough, sir, for you. Duodenotomy via a longitudinal incision. That means duodenum is opened longitudinally and it is a 3-point you stitch. You are stitching at 3 points. You do not take any chance. So gastroduodenal artery has to be stitched at 3 points and you are closing incision transversely. This is a surgery. It is called a Finney's pyloroplasty. If the patient chances of rebleed are more, the surgery is done. That surgery is total vagotomy with pyloroplasty as an emergency. So this chart is of the classification and the treatment. If you remember this much, it is a flying color. But we may go into the slightly details of this. So what are the details? The treatment schedule, how do you manage the treatment? This is schedule. The patient has come to you. Treatment of shock, blood transfusion, stomach wash, pentop, endoscopy sclerotherapy, bipolar coagulation, laser, angiography immobilization if renal is available. If no response, open surgery, underwriting of the bleeding vessels, ligation of GU artery, and Finney's pyloroplasty. That means longitudinal incision is sutured horizontally. PPI must be started at the time of discharge and repeat gastroscopy after 3 months. So this is a treatment schedule of a bleeding duodenal ulcer. And remember, sclerotherapy is the most popular endoscopic method used as present. This is very simple and this DM gastro are doing just within 2 to 3 minutes and patient is saved. See the advancement of a surgery, advancement of the technique. Okay. So this is for more advancement. Just remember the protocol of resuscitation. Step 1, resuscitation. Pulse rate more than 100, 20 to 40% blood loss. Second, history of the patient should be taken. Now, what is see the change of the management? First, you have to manage the general patient. It is not the bleeding. You are directly going to stomach and stop bleeding. You have to see his airway and breathing. Always give importance. The active trauma score, that is airway and breathing and BP. So these things are more important than bleeding. First, try to settle the patient and stop the bleeding. Okay. Locating the source of bleeding by endoscopy. And here endoscopy is within 6 hours by the new guidelines. But if the patient is stable, you can wait for 24 hours. So for stable patient, endoscopy within 24 hours. Stage 4, you have to stratify the risk by our Forrest score. The scores are two types. The score for risk stratification with endoscopy, it is Rockall score. Without endoscopy, it is Blatchford score. This is somewhat higher level. If possible, try to remember or forget. Okay. So this graph also, if possible, try to remember. It is the Blatchford score and Rockall score. This is for what? Risk stratification criteria for upper GI bleeding. How much risk is there? BUN, HB, BP, PR and presence of melena. Criteria is very simple. Nothing very extraordinary. For Rockall, age, comorbid conditions, magnitude, transfusion requirement, endoscopic astigmata. They have given a name to what we are doing. So Rockall score is which we commonly follow. Okay. And what are the risk criteria are? This is 5 criteria are bleed. B-L-E-E-D. B stand for bleed ongoing. L for low BP. E for elevated prothrombin time. E for established mental alteration. This is bad. Mentally altered patients are having constant or irreversible shock. And D stand for with which patient disease associated. If it is because of the liver or because of hepatic failure, the prognosis is bad. How to stratify the risk? Okay. Now comes the current indications of surgery. This current indication is they have upgraded to 6 units of blood transfusion. If they are given, you need to operate. Failure of endoscopic treatment, a recurrent bleed, shock, continuous bleeding, or patient needing more than 3 units per day. Early endoscopy advantages is a decreased blood transfusion. Early endoscopy has got a major role to play. Decreased blood transfusion, short hospital stay and reduced need for surgery. Aggressive saline wash. I told you saline wash should be aggressive. You need a clear vision. And angiography can be imaging blood rate even if it is minor, that is 0.5 to 0.1 ml. 0.5 to 0.1 ml bleeding per minute is also diagnosed with the help of angiography. So selective angiography is a more specific investigation. T19 RNA available, embolization and angiogram. So these are the advancement for gastroenterologists. So we have finished regarding whatever said about the gastric bleeding, that is upper GI bleeding through duodenal ulcer. Now we are coming to one of the question which is not very common but it has been asked. This we have to consider how. Here this question is write the etiology, clinical features, staging and management of carcinoma of the urinary bladder. This question you must be able to write down in detail because either this question or some short note is always asked. I will give you an idea about it. What are the bladder tumors? They are very common. Don't say that they are not common, but fortunately for us, they occur in an older age group. What they are? Unfortunately, they are most commonly a malignant tumors. Bladder tumors, benign, are rare and they are called as a urothelial tumor. That means arising from the bladder mucosa and endothelial, like what you see the different layer. That means communication of the bladder to the umbilicus. That cord also, urogenital cord, can also give rise to malignancy. So benign tumors are rare and commonest cause type of carcinoma is TCC. That is a transitional cell carcinoma is most common in bladder. And what about kidney? It is RCC. It is TCC for bladder, RCC for hypernephroma, that means renal malignancy. That is clear cell carcinoma. Renal cell carcinoma is by definition. RCC is renal cell, TCC is transitional cell. This type of malignancy can be primary or secondary. What are the primary tumors? Pathological differentiation, epithelial and connective tissue. Everywhere epithelial are probably more common. So what this TCC is? It is an epithelial tumor which is 90% common. Second is adenocarcinoma. And see here, it is arising from urachal remnant or in extravascular of the bladder. This is unfortunate. But extrafilm bladder, the condition which occurs because of fusion of the anterior wall, is more common for undergoing malignant change. Then squamous cell carcinoma, this is also common. The cause is bilharzial infection and calculus. So don't take calculus lightly. Calculus is also one of the risk factor for malignancy of bladder carcinoma. Epithelial tumors, connective tissue tumors. What are they? Myoma, angioma, and extra-adrenal pheochromocytoma. See, pheochromocytoma occur usually at the adrenal, but this can be extra-adrenal tissues. Some adrenal tissues are left into bladder. And secondary, where from they occur? Secondaries in the bladder can occur from sigmoid colon, rectum, and in female uterus, ovary, and in males prostate. So these secondaries which are nearby the bladder can give by local invasion. They are the secondaries into bladder carcinoma. So this is desirable. Remember this. Most common benign mesenchymal tumor of the bladder is leiomyoma. Most malignant tumor, leiomyosarcoma. These are connective tissue tumors. Myoma and sarcoma, very bad. Leiomyosarcoma, very bad. In children, it is embryonal rhabdomyosarcoma. This is just try to remember if possible. So, in general, what are the risk factors for carcinoma of the urinary bladder? They are always asked. Risk factors, that is etiology. For a TCC, that is transitional cell carcinoma, the risk factors are most common cigarette smoking. This smoking is responsible for 50% of the RCC, the TCC bladder carcinoma, 50%. And second most important is the occupational exposure. Here many of the malignancies related to GUT, that means genitourinary tract, are related to benzidine aniline dyes. So this is where our person works. If he works into this dye industry, he does stand chances of undergoing or having malignancy. Second is common for infection. The infection has a major role to play in genitourinary tract, because you see many of the stones are also formed by the foreign body. So the organism is Schistosoma hematobium. This is type of organism which can give rise to malignancy. Common malignancy is SCC or squamous cell carcinoma. So this drug cyclophosphamide, the question has come on this. What it says? Ideally cyclophosphamide is an anti-malignancy drug. It is a chemotherapeutic drug. But this drug also can cause carcinoma of the bladder. You must write down this. Other causes: pelvic irradiation, industries like chemical industry, dyes, rubber, leather, and printing industry, where all these types of dyes are used. This is regarding TCC. It is 90%. Sometimes you get squamous cell carcinoma. And risk factor number 1 here is Schistosoma hematobium, this organism. And chronic irritation, this is the secondary cause. Chronic irritation due to what? Urinary calculi. And long-term indwelling catheter. If you keep a catheter for a very long time, there is a chances that this type of carcinoma may develop. So, as a principle, remove the catheter at earliest stage. And bladder diverticuli. Bladder diverticuli occur because of a outflow obstruction to the bladder, like prostate or a long-standing stone. In that diverticula, malignancy can occur. Okay. So, these are the risk factors. Now, coming to the comparison of different types of malignancy of the CA bladder. Don't go into the detail. Simply TCC are 90% and they are mostly papillary or exophytic lesions. Remember, this type of lesions are more easily accessible to the management. SCC, squamous cell carcinoma, it is also called as a bilharzial carcinoma because the cause is organism. It is rare, maybe 5%, 10%, and here this is arising from the lateral border or dome. Okay, this is usually appearing at the apex. TCC at the apex, SCC at the lateral border. They are invasive. The moment they become invasive, the prognosis is bad. Because of that, they do not respond to TURBT with transurethral investigation. That means pressure, transurethral TURBT, partial cystectomy or chemotherapy. This is a bad tumor. So the treatment is a radical cystectomy is a treatment of choice. Okay, this is a major difference for SCC, but the prognosis is almost same. So this is a bad cancer, squamous cell carcinoma. Adenocarcinoma, equally bad, occurs in 2%. Where does it occur? Urachal remnants and ectopia vesicae are the risk factors. Types: vesical, urachal, metastatic. Here primary is at the floor. So see where the primary is situated, that will give idea about the pathology. Radical cystectomy is a treatment of choice and this does not respond to chemo or radiotherapy. Chemotherapy is important for a carcinoma of the bladder, but this does not respond to chemo radiotherapy. Okay. Now coming to the common question, what are the clinical features? They are very simple. First, they are most common in males. In females, they are rare. The presentation is painless hematuria and patient getting chronic anemia. This is the presentation. Patient may have ascites, cystitis, inflammation of the bladder, suprapubic pain, frequency and dysuria. These are somewhat disturbing because they are all same for the prostate. The signs and symptoms of BEP are same. Only difference is this patient have got painless hematuria. Otherwise everything is same. But prostate rarely present with hematuria unless you are passing a catheter which is not going. Traumatic hematuria is common in prostate, but it is here painless hematuria. Long-standing tumor obstruction gives rise to hydronephrosis. And if hydronephrosis, then pain in the brain, back and peritoneum, and lately invasion of the pelvic wall. So remember only painless hematuria, anemia and suprapubic pain frequency. This is more than enough. How do you investigate? Common investigation. Urine microscopy, IVU, intravenous urography. If this is done, in the end it will show distortion and the filling defect. That means the growth will show the fluiding defect in the bladder and long-standing cases hydronephrosis. But IOC of choice is cystoscopy. Why this? You can take a biopsy as well as treat the pathology. And in late stages, it is bimanual examination. That means you have to palpate the bladder. In rare cases, when the this tumor is very large, you can palpate the tumor per abdomen. But commonest for us investigation is USG abdomen. This USG will clearly show us the carcinoma, wall and pelvis, and CT and MRI for evaluation of invasion and extension. So CT MRI to see the prognostic value, USG for diagnosing, and bimanual palpation for a high level. But IOC is a cystoscopy for a carcinoma of the bladder. So they have asked about TCC. We have discussed everything. TCC most common, and it is the fourth most common non-dermatological cancer in man. Remember, commonest cancer is dermatological and carcinoma bronchus, and then prostate, then comes this. Okay, and etiology. Remember 3 C's. What are they? Chemical carcinogen, number 1, cigarette smoking, and third, cyclophosphamide. So these 3 C's are the etiology of carcinoma of the urinary bladder. Cyclophosphamide we have discussed. This is anti-malignant drug, but known to cause bladder malignancies. Chemical carcinogens and occupation. Occupation wise, textile, dye, cable, tire, petrol, leather workers, Remember, your petrol workers in petrol pump, they are also vulnerable for having carcinoma bladder. Don't tell them. They will be afraid and they may leave the job, but they are vulnerable. And the most important is chronic irritation due to bladder stone and schistosoma hematobium. This is an organism. So different classification. You can just hear this and forget. Classification 1, non-muscle invasive. Non-muscle, non-invasive, where involvement of lamina propria, no involvement. Muscle invasive and carcinoma in situ, they are non-invasive. Because these are the different types and these are the pathological classification. Okay, but they have got a malignant potential. If occurring alone primary carcinoma in situ, unfortunately it has got a high mortality rate, potentially malignant, which is secondary carcinoma in situ. Okay, this is regarding the carcinoma in situ. Classification 2, superficial bladder tumor like papillary, muscle invasive TCC and carcinoma in situ. So carcinoma in situ here can be papillary or villus type. So remember simply, superficial bladder tumor, muscle invasive tumor or carcinoma in situ. These are the classification 2. So number 1 is depending on the invasive and involvement of lamina propria plus minus plus carcinoma in situ muscle invasive. Number 1 classification. Second classification, superficial and muscle. And third, carcinoma in situ. These are the classification. For other than that, you remember the sites. Most common site for them is lateral wall, 35%. Next common is trigone. This is regarding the position of the malignancy. And this is the staging. 1, 2, 3, 4. You remember this. This is invasion, non-invasive of the muscle, invasion of the muscle, evasion of the muscle, and local interference going out. So this is the staging of a bladder carcinoma. You may remember the TNM staging. Sometimes they are asking. CS staging is again TNM. T is a primary tumor, N is lymph node, and M is metastasis. TA, non-invasive. TIS, in situ, this is a flat tumor. T1, it has invaded subepithelial connective tissue. Now layer by layer. T2A, invasion of the inner half. T2B, invasion of the outer half. T3A, extension to perivesical fat. And it is microscopic. T3B, macroscopic extension. So remember here, muscular papilla positive, negative. If it is negative 2A, positive 2B. T4, cancer has invaded into pelvic viscera, that is prostate and rectum. And T4B, extension higher up to the side wall or abdominal wall. Okay, this is the T classification. N for single regional lymph node, multiple regional lymph node, and metastatic lymph nodes. This is 1, 2, and 3. N1, N2, N3. M1, M0, no metastasis. M1, distant metastasis. So, in nutshell, any T, N, and M plus, that means M plus comes, it is grade 4. And the management is systemic chemotherapy followed by elective surgery or irradiation. So, coming to the management. Treatment is for all non-invasive tumors. Here we are going to T1 or 2B. Commonest is endoscopic resection of tumor. This is possible and gives very good result. Endoscopic resection of tumor. Intravesical chemotherapy using BCG. This, if you write down these 2 lines, more than enough. Endoscopic resection and chemotherapy local using BCG. If you want to go to detail, here BCG is for the tuberculosis, Bacilli calmette-guerin. The dose is 120 mg in 150 ml of normal saline weekly for 6 weeks. Okay, you have to introduce this much of saline into the bladder for 6 weeks daily, once in a week. This is very helpful. Other drugs are mitomycin, adriamycin, methotrexate for carcinoma in situ. Sometimes systemic chemotherapy, cisplatin, 5-FU. Other is degeneration therapy. What they are doing? By producing a pressure over the vesicle tumor, they are degenerating in the large papillary tumor, reducing the size. Sometimes deep X-ray therapy. And for invasive tumors, it is surgery plus chemo plus radio. You remember only endoscopic intravascular chemotherapy, and for invasive surgery, chemo, radio. This is in nutshell. If you remember this graph, everything will be easy for the management. For a TIS, that means carcinoma in situ, treatment is intravesical BCG. For TA, single, low to moderate grade and non-recurrent, the treatment is transurethral resection TUR. If you add P, it will be TURP. Same like it is a TUR, resection of a malignancy, gives very good result in TA. For the large tumor, TA, it is complete TUR followed by chemotherapy or BCG. BCG has proven to be a winner in this malignancy. All conditions from T2 to T4, treatment is a radical cystectomy is a treatment of choice plus neoadjuvant chemotherapy. In all T4, T3, you simply write down neoadjuvant chemotherapy. That is more than enough. This shows that you have understood something more has to be done. Okay. And any T, any N plus, systemic chemo, radiation plus selective surgery. So, just remember what is BCG? It is an attenuated strain of Mycobacterium bovis. It is the most effective intravesicular chemotherapy, and TOC, treatment of choice for carcinoma bladder. Side effects are frequency, urgency, dysuria. In some rare cases, BCG sepsis. This graph you remember, you are the master of the treatment of carcinoma bladder. Okay. And with this indication of surgery, simply remember multiple bladder tumors, sessile tumors, recurrent tumors, poor differentiated tumors, in situ carcinomas, squamous cell carcinoma, adenocarcinoma. Here funny part is in situ carcinoma, here BCG is not going to act. So you have to go for cystectomy. Okay, so these are the indications of surgery. Partial cystectomy and radical cystectomy. There are the two types of surgery. Most of them are followed with the radiotherapy and chemotherapy. In radical, what we are removing? Remember, what we are doing here is bladder, urethra, paravesical tissues, lymph nodes in the pelvis are removed, and in female, hysterectomy with the removal of vagina is also done. See the gravity of surgery. It is a very major surgery, radical cystectomy. Okay, so it is better to identify the tumor earlier. Prognosis, it depends on the type. If it is TCC alone, that means transitional carcinoma, 85%, 5 years survival. TCC with SCC, very poor, 6%. And only SCC, that means squamous cell carcinoma or adenocarcinoma, only 3%. So our TCC is the treatment of choice. For us, if patient had TCC, we are happy. If patient has got SCC, we are sad. Okay. And I say thanks to you, thanks for your patient hearing, and enjoy. Good day, good evening. Thank you.